We're going to go straight into now presentation from Fiachra. Fiachra Bane is the interim head of the Healthcare Pricing Office, HSE. This is his baby, and he's going to be guiding us throughout the day and explaining all. Thanks, Fiachra.
Thanks, Sarah. Thank you, Robert.
Actually, sorry, one quick note before you start. Don't forget your Slido questions. We have screens here in front of us, so if something occurs to you while Fiachra is speaking, let me know straight away and put it into the Slido. Thank you. Sorry,
Thank you.
Off you go, Fiachra.
So just following on from Bernard and Robert, what I'm here to do is kind of set the context, I suppose, for what's happening in the ABF scene at the moment and over the next, the rest of the year. Okay, that's going to have to go. So just in terms of what ABF is, in a nutshell, it's linking the funding of a healthcare institution to the activity that's undertaken. The goal is to increase transparency, encourage efficiency, ensure fairness in funding. And there are a multitude of implementations in that internationally, and we'll speak about our own very briefly. The genesis of ABF and case mix was actually in the Department of Health back in the day, and Brian Donovan, who, if you were expecting to see him here this morning, I can only apologise. Brian retired there recently enough and is fully enjoying it, I can assure you. Activity-based funding, as we know it now, was started in Ireland in 2016. We were setting prospective prices for DRGs for inpatients and day cases. And the bread and butter of that model is a relative efficiency model where we benchmark hospitals one versus the other. It is a broad measure as it's currently implemented, and there aren't too many focus areas in there. The annual process in a nutshell, these are just the components. So obviously it begins with a patient being treated in one of our hospitals. They're discharged and their information is put onto the HYPE system, clinically coded, and that allows us to assign a diagnosis-related group. Our costing team then will take that information and it goes through our patient-level costing process to provide a cost for all of the treatment of those patients. And based on that information, we can derive an average price for those treatments. And the benchmarking exercise essentially says, what has it cost the hospital in a given year to provide that treatment versus what is the average cost in the year versus their peers? And that's really the essence of benchmarking. In terms of the scope, or the current scope of ABF, the current scope is inpatient and day cases, so around 700,000 inpatient discharges annually and around 1.25 million day cases. So we're pretty much creeping up, knocking the door on the 2 million mark of admitted patients. So it is increasing. The future scope, so this is what we're currently working on, and there'll be sessions this afternoon in terms of that, is outpatients. We're looking at potentially 4 million sessions. Attendances in outpatients, depending on whether it's just consultant-led clinics or whether that's broadened out into ANP-led clinics, and then into the ED and injury unit. So again, another 1.2 million attendances that we want to bring in under the scope of ABF. We want to be able to know more about these patients clinically, who they are, why are they coming to our hospitals, and actually have the full picture of what's happening there, and then branch out then into community eventually. So in terms of the current financial scope, as we said, the acute hospital portion of the 24 billion was 10.9 billion for 2025, and ABF covers about 7.1 billion of that. So that's our admitted patients, inpatients and day cases. And currently that's about 65% of their budget. When we bring outpatient and ED, that will increase to over 90%. That will be covered by ABF. There's always going to be a portion that's not in ABF because there are activities in the hospitals that are not related to the patients in the hospital. Lab tests for GPs is a primary example of that. So what does it look like when we do ABF benchmarking? Well, typically what we see is this bar chart on the top left, and essentially those hospitals to the left are hospitals that are more expensive than the average based on their mix of cases, and those on the right are less expensive. So the negative means it would result in a negative funding adjustment for the following year, and vice versa. The red lines are currently the impact that the hospital feels. So that's currently at 25%. So essentially they're cushioned to the tune of 75% of the overall impact. And what, Bernard had mentioned and Robert, and as part of the discussion is, how do we move to make that, to reduce that amount? Just in terms of context, it's plus or minus sort of minus 10 million to plus or minus 10 to 15 million. In terms of the percentage of overall budgets, it's plus or minus 20% in the ABF expenditure at no transition adjustment, plus or minus 5% of ABF expenditure for a given hospital. In terms of their overall budget, plus or minus 14%, without a transition adjustment, plus or minus 3.5%. So there are significant amounts. There is an impact, and it is real when those amounts start to come down. Just in terms of the questions then that these kind of figures are asking is, look, how quickly can we move that transition adjustment down to zero? Can that actually fully go down to zero, or do other mechanisms need to be put in place besides that? And I guess what the theme of today mostly is, what other ABF mechanisms can we put in place to promote efficiency? Not instead of what we currently do in ABF benchmarking, but alongside what we currently do. I think this graph is one of a few that we've seen in the same theme, and refers back to some of the figures that Robert would have mentioned. The red line there is the increase in cost over the last 10 years, and the blue line is the increase in activity. So obviously you can see quite clearly that one is outpacing the other. You can see a very clear impact of COVID there, where you start seeing the two lines diverge. And this is where a lot of the context of where we are today comes from. It was a lot of the context for a lot of, let's say, robust discussion between ourselves and our department colleagues over the while as to what this can and can't say about productivity. Regardless of the outcome of those conversations, I think it's still incumbent on us. We're public sector workers, and we need to make sure that we are doing everything for our patients with the money that we have. That's what it looks like in terms of the average cost for treating a patient over that 10 years. So quite a step there pre-COVID. And again, the questions, this is part of an international trend, is this productivity question. Why are we not getting more output from the health systems in general for the money that's going in? What does that tell us about productivity? And again, what is that relationship? What should it be? And I think that's the question we don't know particularly well at the moment, is what should that relationship be between cost and activity? And again, how do we ensure that we're using the mechanisms that we have to promote efficiency and productivity for a sustainable healthcare system in the future? So a couple of cases for examining how we implement ABF. There certainly is a perception out there, and it's one we've heard, that the current benchmarking is opaque, a little bit academic, and it's difficult to know exactly why, for a hospital, exactly why you've come out with a particular position. It's based entirely on relative efficiency versus peers. So even if a hospital is improving performance versus themselves year on year, if that improvement isn't keeping up with the overall system, you'll still end up with a negative adjustment. It's an all-in-one comparison apart from a couple of areas. So literally all activity, all cost is put in, and there's not really a lot of differentiation, not a lot of focus areas. I think the exceptions are the hip fracture, best practice tariff, and there's some pricing signals for lap choles. And also the benchmarking is based on the prior year's data. That's by necessity. It's the latest data that we do have, but it's a critique that we would typically hear. On the other hand, there's a huge amount that ABF can do, and I think it's well acknowledged, with our department colleagues and with leadership within the HSE, that it has a hell of a lot to offer in terms of managing our healthcare system. It's widely used international for those reasons. It can generate an awful lot of insight. The methodologies are very flexible, so they can be implemented in multiple care settings, ... as long as there's data and costing to go with it. And we'll have a lot of conversation about that later on. It has a lot of potential to focus on specific priority areas, and the hip fracture, the best practice tariff in that area has been very successful and something we might like to replicate elsewhere, and great potential to promote high quality care as well as productivity, because we always need to make sure that what we're doing is in the best interest of the patients. So for what we're planning to do, it's kind of under two headings. The first is expand. So you'll be hearing talks this afternoon in relation to where we are at the moment with the outpatient classification and with the clinical coding of ED discharges. So there's going to be a couple of interesting updates on that. And we're also looking at a national implementation of patient level costing, which is the gold standard of costing information that we can have. We want to make that the standard across all hospitals because we think it will really benefit the quality of the insights that we can draw from the data. On the improvement side, we want to increase the access and use of the data that's there. So we will be presenting a new activity tool, an ABF activity dashboard, which seeks to make data more readily available to more people in the system. So we'll have a presentation on that. I'm not going to go into it anymore. We have the deep dive exercises, which are going to be starting off pretty much next week, where we're going to go to the hospitals. There's going to be costing and coding reviews, but more importantly, an operational review within the hospital, using the data in the tool to really understand what a hospital can do in terms of the context of their ABF performance. And the last one then is explore and recommend additional ways that ABF can promote productivity. So this is what Stephen has put on my to-do list for this year. And it's an interesting project, and we will be asking for input from all stakeholders. So the scope of that review is really research alternative ABF measures and mechanisms that we can implement in Ireland, focus on productivity, efficiency and quality. Try to link that to current healthcare priorities where possible. If we have good initiatives, we have priority areas and we have data, then let's link that into ABF where we can. But also set smart goals. These things have to be achievable, measurable, for us to get any traction with them. So we are asking, and I've a short session at the end of the day, it won't be long, but we are asking for consultation. We have an ABF consultation period every year. I think this is a particularly important one because we do want to get input from people in the regions and the hospitals on the ground. How can we change ABF to promote efficiency, productivity, and the quality of care that we're giving? And the output of this for this year is going to be a report and recommendations, and we really do want to include the input from the ABF community in that. Just in terms of if you are, and I hope you do, putting in submission things that we want you to consider is, what are the supporting data sources? Is there evidence of efficacy? Have people done this before? What's the administrative burden? And then things like, what are the methods of incentivisation or disincentivization? Is it explicit payment? Is it a reduction of payment if it's an avoidance type thing? Is it related to access to future funding? And then there's also the question of the method of funding. So is that top slicing? Is there a separate funding pool? I think those will be conversations that will have to be had with Stephen a little bit later in the year. And just as a special request, we were definitely asked to speak about the identifiers on HYPE and our ABF data. So just in terms of the IHI, currently it's 60% across all of the HYPE records. So HYPE is set up currently to accept the IHI PPSN. It's 80% in IPIM sites, so good progress, but plenty still to do. I think 20% is still a lot. The HIDS team are actively working on that. That the IHI isn't actually on the current hype file that's going out. Brian McCarthy's working on that, so it will be there. It will be there soon, but it is coming down as part of the downloads. The PPSN, we're active campaign to get that on at the source, which is probably the best place for it. And there are seeding exercises underway from the HIDS team to use existing data sources under IHI to start seeding that into the primary systems. So there's going to be a wider rollout of that into hype, linked with other updates to those IPIMS and PAS systems just during the summer. And again, hype is, we have future-proofed hype, so once that is available, it will flow down to the hype and add a lot of value to the hype data set. In terms of error code, again, that's currently being collected on hype. The full error code is there for about 40% of hype cases at the moment. Again, that's reflecting what's in the primary systems. And, we would prefer that information to come from the primary systems, but there is a work ongoing with the HPO where we're looking to see if we have access to addresses, are we able to reliably put an error code onto those records. That's something we're looking at the moment. We'll have to have conversations about coverage and quality in relation to that, but hopefully we can bring that 40% from the primary systems up and still retain the quality of that information, because it's even more relevant now in the terms of regional healthcare. So I will leave it at that before I'm hauled off the stage, and thank you very much.
Thanks, Steve.